New Zealand's psychiatry shortage can weaken the machine meant to solve it. In 2026, 1 in 5 funded public positions remained vacant. Half the existing workforce could pass retirement age within 10 years. Hiring more trainees sounds like the obvious answer. But every trainee needs experienced psychiatrists for teaching, supervision, and safe clinical work. The shortage can therefore remove its own future teachers. That is the trap inside the workforce numbers. First, a psychiatrist is a medical doctor. Psychologists, nurses, counselors, social workers, and peer workers provide essential mental health care. Their skills overlap in useful ways. They are not interchangeable job titles. A psychiatrist assesses illness through both mental and physical health. They can diagnose complex disorders and use medical treatments. Specialist registration also allows independent practice and supervision of other doctors. That role becomes especially important in severe or complicated illness. The route into the job is long because the responsibility is large. A medical degree usually takes 4 to 6 years. A graduate then completes an internship. 5 years of specialist psychiatry training follow through the professional college. The program includes work in several kinds of service. Trainees learn adult, child, and hospital-linked psychiatry. They treat real patients while senior doctors supervise their decisions. Examinations and workplace assessments test progress. Finishing the calendar is not enough. The doctor must show the required judgment and clinical skills. This creates 2 limits on growth. New Zealand needs funded training jobs. It also needs enough suitable teams and supervisors around those jobs. Money can create a position quickly. It cannot create an experienced specialist on the same day. The National Workforce Report shows the scale of the problem. Its snapshot counted 709 psychiatrists across all sectors. Public services funded about 550 full-time positions. About 106 of those positions were vacant. That was a 19% gap. The average psychiatrist was 55 years old. More than half were already older than 55. There were 228 psychiatry trainees. That may sound like a strong replacement group, but retirements are not the only gap they must fill. Vacancies already exist. The population continues to grow. Unmet need remains outside the funded job count. Some specialists work privately rather than in public services. Rural areas and smaller specialties struggle more than national averages reveal. Child and adolescent services provide a sharp example. Their public vacancy rate reached about 24% in 2026. The training report modeled one possible domestic response. Active trainee numbers would need 10% growth each year for 5 years. That would address vacancies and lift the share trained in New Zealand. Even that plan would take years to produce independent specialists. Meanwhile, older psychiatrists would need to keep treating and teaching. New Zealand has another important source of doctors, about 60% of its psychiatry workforce trained overseas. International recruitment is not a temporary footnote. It is one of the system's main supports. Overseas specialists bring experience that patients need immediately. They can also become supervisors for local trainees. New Zealand still must check qualifications and recent clinical experience. Some new arrivals need supervised practice before full specialist registration. Countries also compete for the same small pool of doctors. Recruitment can fill a chair faster than domestic training. It cannot guarantee that the doctor stays. Retention is therefore part of training policy. An exhausted senior doctor may reduce hours or leave public work. That removes clinical time. It may also remove supervision capacity from several future doctors. One departure can echo down the pipeline. This helps explain two statements that appear to conflict. Health New Zealand can exceed an annual workforce training target. Psychiatry vacancies can remain severe at the same time. The broad target covers several mental health professions. It measures people trained during a year. A vacancy figure measures empty funded work across the existing service. One is movement through a pipeline, the other is the whole waiting at the end. Training nurses, social workers, psychologists, and occupational therapists adds real capacity. It does not instantly create a psychiatrist. The same warning applies to raw headcounts. One person may work less than a full-time week. Another may divide time between public and private care. A trainee is a working doctor, but not yet an independent specialist. Good workforce planning follows hours, skills, location, and supervision. It does not celebrate one large number. What would loosen the trap? More medical students must see psychiatry as a serious career early. More junior doctors need supported routes into training. Training posts must exist in places with enough supervision. Senior doctors need workloads that leave time to teach. International specialists need fair and efficient registration. Public services must give trained doctors reasons to stay. Other mental health workers should practice at their full skill level. None of these moves replaces another. Together they protect both today's appointments and tomorrow's teachers. The deepest shortage is not visible in an empty consulting room. It appears years later, when nobody is available to fill that room. Every vacant senior chair can also remove part of the classroom.